In this series, we have been focusing on obstructive lung diseases and have now just covered chronic obstructive pulmonary disease, or COPD, in detail. Next, we will delve into asthma. And just to briefly review here, what unites these obstructive lung diseases is that in all of them, we are going to see a drop in both the FEV1 as well as the FVC, or forced vital capacity. However, the drop in the FEV1 will be greater than the drop that we see in the FVC, thus resulting in a decrease in the FEV1 to FVC ratio, which is a hallmark of obstructive lung disease. Without further ado, let's delve into asthma in detail. The key in the presentation of asthma is that patients are classically going to have intermittent symptoms. These intermittent symptoms include cough, wheezing, which occurs on both inspiration and expiration, shortness of breath, and additionally, these patients tend to have symptoms that are worse at night, which can thus result in nighttime awakenings for these patients, which can be extremely distressing, especially in the pediatric population. The pathophysiology underlying asthma follows a classic triad. This classic triad includes airway inflammation, airway hyperresponsiveness, and very high yield to keep in mind, reversible airflow obstruction. And we will discuss the reversible nature of this airflow obstruction in more detail in the coming slides in the context of spirometry in our asthmatic patients. While it is possible for patients with asthma to have a non-atopic form of asthma, this tends to be rather rare, and therefore most of our patients with asthma, especially on examinations, are going to present with other manifestations of atopy. This includes having a more pronounced IgE-mediated response, having eczema, as well as hay fever. It is also essential that we understand the triggers which contribute to asthma, as we can often recognize these in exam vignettes. These triggers include pollen, dust, mold, pets, cold air, viral infections, smoke, including cigarette smoke, beta blockers, and as we will see in the coming slides, this is why we actually use beta agonists as treatment for asthma, aspirin, as we see in the context of AERD, which we will discuss in more detail later in this module, as well as exercise. Consistent with the fact that asthma is an obstructive lung disease, when we perform pulmonary function tests, or PFTs, our asthmatic patients are going to have an obstructive pattern, namely that they will have a decrease in their expiratory flow rate, a decrease in their FEV1, and the FEV1 decrease will be more pronounced than the decrease in their forced vital capacity, or FVC, thus resulting in a decreased FEV1 to FVC ratio. And this can be further appreciated in our schematic on the right-hand side of the presentation, where we can see the patient's volume exhaled compared against time. And as we can clearly see, the FEV1 in the case of obstructive diseases is significantly decreased compared to our normal patients or restrictive disease counterparts. This decrease in the FEV1 and the patient's inability to essentially blow air out is also reflected in the flow volume curve that we classically see on examinations. As you can see, if we look at the y-axis here, when we go above the x-axis, this is going to refer to expiration, and when we go below the x-axis, this is going to refer to inspiration as we move towards more negative numbers. This flow volume curve, as we can see, is classic for a patient with asthma or of obstructive lung diseases more generally, as we can see that this patient clearly has a more difficult time when it comes to exhalation. Rather than having a nice smooth outward flowing of air, the patient has an obstruction, thus causing this to slope downward in this concave fashion. And this is highly characteristic of the flow volume curve that we would expect to see in our asthmatic patients. Also related to this pronounced decrease in the patient's FEV1, we can also use a tool called a peak expiratory flow rate, or peak flow, in order to monitor our patient's disease course in the case of asthma. It should also be noted that the use of a peak flow using a peak flow meter, as pictured at the bottom of the presentation, is the fastest way to diagnose asthma. This makes the use of the peak flow meter ideal for emergency department and acute settings, and additionally, the peak flow meter can be used in the case of patients with moderate to severe asthmatics on a daily basis in order to monitor the course of their disease. And although the use of spirometry and full-blown pulmonary function testing is preferred in order to get the most accurate diagnosis of asthma, the peak flow meter can still be extremely helpful in that it allows our patients to have a more portable way of assessing what is essentially a proxy for their FEV1 value, thus allowing the patient to monitor the severity of their disease course over time. As we have stated previously, the key triad which underlies the pathophysiology of asthma includes airway inflammation, airway hyperresponsiveness, and very high yield to keep in mind, reversible airflow obstruction. This reversibility of the airflow obstruction is something that we actually utilize in clinical practice, as we can perform spirometry in our asthmatic patients before and after administering a bronchodilator. This can be done in the clinic by assessing a patient's pulmonary function tests before and after giving a beta-2 agonist, for example, albuterol. The key cutoff to keep in mind for this is that if the patient's FEV1 or FVC increases by at least 12%, then that patient is said to have reversible airflow obstruction, which is highly suggestive of asthma. Other additional testing that we can perform in confirming a diagnosis of asthma includes bronchoprovocation testing, with broncho here referring to the bronchi and provocation referring to provoking this disease. This bronchoprovocation testing is utilized when asthma is heavily suspected, but pulmonary function testing is non-diagnostic. The most common way of performing bronchoprovocation testing is with the use of a methacholine challenge, methacholine being a cholinergic agent, which leads to bronchoconstriction. In a methacholine challenge, we are able to assess the patient's PFTs before and after inhaling increasing doses of methacholine. And as would be suspected in the case of asthmatic patients, the pulmonary function tests are going to become more obstructive in terms of their pattern at lower doses compared to normal patients. Additionally, if there is at least a 20% decrease in the FEV1 in response to the methacholine challenge, then this is considered to be diagnostic for asthma. In addition to these variations on pulmonary function testing, we will also sometimes obtain a chest X-ray in patients with asthma. This is typically reserved, however, for severe cases, especially in the context of acute exacerbations, and this is performed in order to rule out pneumonia and pneumothoraces. And as we see in the case of other obstructive lung diseases, in the case of severe and long-standing asthma, we may see hyperinflation of the lungs on this chest X-ray. When it comes to the management of chronic asthma, there are several key agents that we will need to be aware of. First off, we have our inhaled beta-2 agonists. These can be divided into our short-acting and long-acting beta agonists. Our short-acting beta-2 agonists, abbreviated as SABA, include agents such as albuterol. These agents can be used as a rescue inhaler in the case of acute exacerbations, as well as for exercise-induced asthma. Oftentimes, patients who have asthmatic symptoms with exercise can simply take one of these SABAs within 10 minutes of initiating exercise, and they can have significant alleviation of their symptoms. We also have our long-acting beta-2 agonists, abbreviated as LABA. These include agents such as salmeterol, and these are often reserved for our patients with moderate to severe asthma. Next, we have our inhaled corticosteroids. These are generally used in moderate to severe asthma, as they have been shown clinically to decrease the frequency of asthma exacerbations. Typically, as patients' asthma becomes more severe, we can also consider the use of oral steroids in the case of severe asthma patients. Next, we have montelukast, which is a leukotriene inhibitor. This has several uses, including in the case of exercise-induced asthma, as well as in aspirin-induced disease. Additionally, montelukast can be used in order to wean patients off of steroids and to decrease their steroid use. Other agents you may come across include cromolyn sodium, which is sometimes used in patients with exercise-induced asthma. We also have omalizumab, which is an IgE monoclonal antibody. As we will see in our algorithm in the coming slides, this can sometimes be used in patients with severe persistent asthma. And also, as we have hinted at now a few times throughout this series, we really need to make sure that we avoid beta blockers in our asthmatic patients, as this can lead to bronchoconstriction and worsening of their symptoms. Now that we have introduced the key agents that you are most likely to use in the case of our chronic asthma patients, we now must drive home 3 high-yield pearls in terms of the workup and management of asthma that you must take away from this lecture series. The first of these pearls is knowing how to determine asthma severity, which we will go over in the coming slides. You must also know how to apply the asthma stepwise therapy, which we will also review here in detail. And last but not least, you absolutely must know how to manage acute asthma exacerbations, and we will go through all 3 of these high-yield pearls in the coming slides. The first step in determining the regimen for a particular asthma patient is to determine that patient's severity. A patient's severity can be determined to be intermittent, mild persistent, moderate persistent, or severe persistent. So let's briefly review some of the cutoffs for each of these categories. In the case of intermittent asthma, these patients are going to use their SABA or have symptoms which occur 2 or fewer days per week. In contrast, patients with mild persistent asthma will use their SABA more than 2 days per week. Patients with moderate persistent asthma will use their inhalers daily. And patients with severe persistent asthma will use their inhalers multiple times per day. Moving on to frequency of nighttime awakenings, those with intermittent asthma will have these awakenings 2 or fewer times per month. Those with mild persistent asthma will have 3 to 4 awakenings per month, averaging approximately 1 time per week. Patients with moderate persistent asthma will have more than 2 awakenings per week, but not nightly. And those with severe persistent asthma will have nighttime awakenings 4 to 7 nights per week. And the reason that determining the severity of our patient's asthma is so critical is that this will allow us to determine the particular stepwise treatment that our patient needs. This will make more sense when we view the stepwise treatment ladder on the coming slides, but in the case of intermittent asthma, our patients are going to have step 1 treatment. In mild persistent asthma, they will proceed to step 2. Moderate persistent asthma, they will proceed to step 3. And in the case of severe persistent asthma, they will proceed to step 4 or 5 of the treatment ladder. As we now mentioned on the previous slide, in the case of patients with intermittent asthma, we're going to proceed to step 1, which simply involves the use of a SABA on a PRN as needed basis. Once we move into the domain of mild persistent asthma, we then proceed to step 2 of the treatment ladder, which involves the use of low-dose inhaled glucocorticoids. If our patient has moderate persistent asthma, then we proceed to step 3, in which we can use low-dose inhaled glucocorticoids plus a long-acting beta agonist or LABA, or we can simply use medium-dosed inhaled glucocorticoids. Once we get to the point where our patient has severe persistent asthma, then we are in the domain of steps 4, 5, and 6 of our asthma treatment ladder. At step 4, our regimen involves the use of medium-dose inhaled glucocorticoids plus a LABA. At step 5, we can use high-dose inhaled glucocorticoids plus a LABA and consider the use of omalizumab, which is our IgE monoclonal antibody. And once we get to step 6, we can use medium-dose inhaled glucocorticoids plus a LABA plus oral steroids, and we could also consider the addition of omalizumab to that regimen. So therefore, the overall key here is that you first determine your patient's particular asthma severity. You then decide which step on the treatment ladder that patient should fall into, and then you simply know which medications based off this ladder that patient is going to respond best to, given their severity. Now that we have discussed the management of chronic asthma in detail, we will now review acute asthma exacerbations. Our classic presentation in the case of an acute asthma exacerbation is a patient who is in acute distress with difficulty speaking complete sentences. They may also experience tachypnea, wheezing, diaphoresis, use of accessory muscles of respiration. As these patients' expiratory phase becomes longer, they may have a decrease in their inspiratory to expiratory ratio, also known as the IE ratio. Additionally, if these patients have paradoxical movement of their abdomen and diaphragm during inspiration, then this could be a sign of impending respiratory failure in the context of acute asthma exacerbations. Not surprisingly, in the case of an acute exacerbation, our asthmatic patients are going to have a decrease in their peak expiratory flow. Their ABG, or arterial blood gas, is going to show an elevated AA gradient, and we should also get a chest X-ray in these patients in order to rule out pneumothoraxes and other potential contributors to their symptoms. Going a bit deeper into the ABGs that we would expect to see in our asthmatic patients, it is super common for our asthmatic patients in general to have some level of hypoxemia and hypocarbia. This hypocarbia is due to an elevated respiratory rate that we see in our asthmatic patients when they are in acute distress. This ultimately leads to them blowing off more CO2, thus resulting in hypocarbia. Therefore, we would normally expect our patients with asthma to perhaps have a slightly lower level of CO2, especially if they are breathing sufficiently in order to ventilate and blow off this CO2. Therefore, if the PCO2 is normal or increased, then this is really a huge red flag that the patient has impending respiratory failure. This is because, as we mentioned above, normally the tachypnea or faster respiratory rate in our asthmatics should blow off that CO2, resulting in hypocarbia. However, as the patient's respiratory muscles fatigue, that PCO2 is going to rise, thus signifying muscular fatigue or a severe obstruction. And therefore, for these patients who have a normal or elevated CO2, or if that CO2 is continuing to rise as we monitor that ABG over time, then we really need to consider invasive measures, including intubation and mechanical ventilation in these patients. Additionally, there are several key medications that we use in our asthmatic patients who are having an acute exacerbation. These include inhaled beta-2 agonists. These are going to be of the short-acting variety, such as albuterol, and can be given via a nebulizer or a metered dose inhaler, or MDI, with a spacer. We also use ipratropium, corticosteroids, and in particular, in the context of an acute asthma exacerbation, we really need to give systemic steroids, namely IV methylprednisolone or oral prednisone, as in this case, inhaled corticosteroids is not going to be sufficient. However, as the patient's symptoms improve over time, then ideally we would taper them down to the point where they are only using inhaled corticosteroids. But initially, in the case of a severe exacerbation, they are going to need systemic steroids, either given IV or PO. In the context of severe asthma exacerbations, we can also give our patients IV magnesium. We should also give our patients supplemental oxygen with a goal oxygen saturation of greater than 92%. And as we noted on the previous slide, keeping an eye on that patient's ABG. If the patient has a normal, a high, or a rising PCO2, then we really need to think about intubation and mechanical ventilation. There are several key complications that we need to be aware of when it comes to our asthmatic patients. This can include status asthmaticus, in which the patient has a lack of response to standard medications. Additionally, as we have now discussed multiple times, our asthmatic patients are at risk for going into acute respiratory failure. This is generally due to muscle fatigue or severe obstruction, which ultimately results in an inability for these patients to properly ventilate and blow off PCO2. Additionally, there are several pulmonary complications, which we ultimately rule out when we get that chest X-ray in our patients who are having an acute asthma exacerbation. These complications include pneumothorax, pneumomediastinum, as well as atelectasis. Now that we have discussed how to classify asthma severity, how to manage chronic asthma with the use of stepwise therapy, and how to diagnose and manage acute asthma exacerbations, we will now finish our discussion here on asthma with a discussion of AERD, which is a mnemonic for aspirin exacerbated respiratory disease. In AERD, our classic triad is going to be severe late onset asthma, and I emphasize here late onset asthma as these patients tend to present in their teens and their 20s rather than during childhood. Additionally, these patients will present with wheezing and nasal congestion, which tends to occur after using NSAIDs or aspirin, and it is important to emphasize here that although this disease is named aspirin exacerbated respiratory disease, that NSAIDs can also ultimately set off these symptoms. The third component of the classic triad in AERD is chronic rhinosinusitis with nasal polyposis. And we have an example here of a nasal polyp in this patient, and this is absolutely classic for AERD. The pathophysiology of AERD, which underlies these symptoms in response to aspirin or NSAIDs, is overproduction of leukotrienes in these patients, and the level of leukotrienes is further increased by aspirin and NSAIDs, thus resulting in wheezing as well as an increase in rhinosinusitis in these patients. Given the classic presentation of this disorder, this can be diagnosed clinically. Management for AERD includes the use of bronchodilators, including beta-2 agonists such as albuterol. These patients may also benefit from intranasal corticosteroids as well as saline, as this can be helpful with the rhinosinusitis. And additionally, because the underlying pathophysiology of this disease is an overproduction of leukotrienes, these patients can also benefit from the use of leukotriene inhibitors, such as montelukast. And of course, as one would expect, these patients should also try to avoid the use of NSAIDs as well as aspirin, as this can ultimately set off their symptoms. That'll do it for now in our discussion of asthma. Next up, we will discuss bronchiectasis, which is our final from the obstructive lung disease group. This is BoardsMD, and this is asthma.